Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, ladies and gentlemen. On behalf of the Emirates Society of Internal Medicine, I welcome you all for tonight's educational webinar, the Pulmonology Wave, the air we breathe. I'm Dr. Fatima Abdul Kareem. I'm a pulmonologist working in Rashid Hospital in Dubai, and tonight I'll be the moderator for the session. Tonight we have two hot topics with two eminent speakers. Just remind everyone to put in the question in the chat box. So at the end of this webinar, we'll be having a small Q&A session. So without any further ado, I'll introduce the first speaker for tonight, Dr. Mohammed Tufail, who is a consultant pulmonologist working in SKMC in Abu Dhabi. He'll be talking about the management of pneumothorax in the year 2022 with a question, are we ready for the ambulatory management? So Dr. Mohammed Tufail, if you can share your screen and we will go ahead.
Assalamu alaikum and good evening, everyone. Many thanks to the organizers of this forum for your kind invitation and opportunity to present on this important topic. So I don't have any conflicts of interest related to this talk. In next 30 minutes or so, we will like to review the current guidelines, how we manage the pneumothorax currently. And in fact, during COVID pandemic, there have been at least 3 randomized controlled trials published, and they did not get as much publicity as they deserve. So I will be talking about those randomized controlled trials. And based on those trials, I will argue that this is the time to change our guidelines and change the way we manage pneumothorax. Pneumothorax is not a new disease. It was described about 200 years ago, and initial management had been through pleural aspiration. And in 19th century, mainly pneumothorax was caused by TB. Fortunately, we got control of it. And then after World War, we started being more aggressive about management of this disease. And I will like to highlight these 2 studies which were published at the same time in thorax in 1966. So in one group from Edinburgh, and this is the service being led by a surgeon. And you know what surgeons like to do. And they manage 242 patients, all of them with chest drains, and half of them had surgery. And the surgery I'm talking about in those times is thoracotomy, to cut the ribs to go into the pleura. And at the same time, another group led by Dr. Stradling from Hammersmith Hospital, London, described another series of 119 patients where they manage majority of the patients by conservative management only. It is interesting to note that these studies were published in the same year and in the same edition of thorax with totally contradictory views. So there have been no definitive agreed guidelines to manage pneumothorax. The current guidelines from different societies and from different countries, they don't even agree how to measure the size of the pneumothorax. You can see that Americans like to measure the distance from apex to the cupula. And if it is more than 3 centimeters, then they call it large. And in UK, they like to measure the size at the level of hilum. If it is more than 2 centimeters, then it is considered large. So there are different ways of measuring pneumothorax size. Sorry. So if I go through these guidelines quickly, so American guidelines from 2001, they mention that if someone comes to you with primary small pneumothorax, is less than 3 centimeters, you just observe, rest of them all have chest drain. So Americans don't like doing aspiration. Contrary to that, British Thoracic Society guidelines, which were published in 2010, and they are widely used in the world, they take into account the size of the pneumothorax, but also breathlessness and chest pain. And they describe if the pneumothorax is large, that is, i.e., more than 2 centimeters at the level of hilum, then you perform aspiration first, and then you try to put chest drain if that fails. And then European Respiratory Society statement in 2015 is more patient-centered, and they are describing that you should take into account patients' wishes as well, how well they are tolerating their symptoms. And lastly, by the size of the pneumothorax, so size does not matter much. But we don't have any clear guidelines. It's all up to you which guidelines you follow. I follow British Thoracic Society guidelines as I come from UK. So essentially, pneumothorax, spontaneous pneumothorax is divided into primary and secondary pneumothorax. If you are over 50-year-old or have got any significant lung parenchymal disease or significant smoking history, then it's a secondary pneumothorax, otherwise a primary pneumothorax. So if you diagnose a primary pneumothorax and you determine the size of the pneumothorax at the level of hilum, if size is more than 2 centimeters and patient is symptomatic, the first line treatment is you do pleural aspiration. If that is a success, then you can consider discharging the patient and follow up in the clinic in 2 to 4 weeks' time. If that fails, then you put the chest drain. In case of spontaneous pneumothorax, there's a different game here because these patients have got underlying lung disease and usually they don't tolerate pneumothorax well. So here, if size is more than 2 centimeters or patient is symptomatic, you directly go for chest drain insertion. If size is between 1 to 2 centimeters, you perform pleural aspiration. And they advise all of these patients should be admitted in the hospital for 24-hour observation. So I put forward a case to you based on these guidelines. So this is a 19-year-old student. He has got no past medical history. He's a non-smoker. He comes to emergency department with sudden onset of right-sided chest pain and shortness of breath. His vitals are stable. And this is the chest X-ray. You can see that at the level of the hilum, it's a large pneumothorax, more than 2 centimeters. So there are different options, and these are all plausible options, really. What will you do? So we have to put these questions to ourselves. Will you insert a chest drain and admit the patient? Will you perform manual aspiration of the air and repeat chest X-ray? Yes, I will do this. And number 2, according to current BTS guidelines, and according to American Thoracic Society guidelines, I will do number 1. What about conservative approach? Will you like to discharge this patient and follow in clinic in 2 weeks, though he is symptomatic? Or you will like to do ambulatory care of this patient and insert a pleural vent or ambulatory device and follow this patient up. Or you will straightaway refer this patient to surgeons to perform a bad surgery. So in next few minutes, I will like to go through the evidence that how the treatment has changed really. So the RCTs I'm going to describe, they are mainly concentrated on doing nothing or ambulatory management. And this concept is quite new as far as RCTs are concerned. The question is, when a patient comes to us with pneumothorax, are we treating the X-ray or the patient? And this is a question we should ask ourselves. And there is no consensus about the need for drainage of large pneumothoraces. And you know, it varies from patient to patient. Some patients are very symptomatic, some patients are not. And in case of a completely collapsed lung and patient does not have any symptoms, many would still like to perform chest drain insertion and insert a big pipe into the chest of the patient. So I have talked about the case series from Dr. Stradling from London, published in 1966, but we did not have any randomized controlled trial until 2020, when Australian and New Zealand group did a very brave trial, really. It is a PSP trial, which had been running for 6 years, and the results were quite awaited, and it was published in January 2020 in New England Journal of Medicine. So basically, what this trial aims at is determining whether conservative treatment is non-inferior to the interventional treatment. Patients are randomized 1-to-1, non-inferiority design, primary outcome, chest X-ray resolution at 8 weeks. 316 patients. They screened lots of patients, 39 centers in Australia and New Zealand, and trial ran over a period of 6 years. It is interesting to know how they manage these patients. Very, very different approach what we do here or in other parts of the world. So in the conservative treatment, a patient comes to ED with primary spontaneous pneumothorax. They will repeat assessment after 90 minutes, randomize, and give the patient some analgesia with paracetamol, ibuprofen, opiates, and measure their OPS, obviously. If patient is unstable, i.e. respiratory rate is more than 30, oxygen saturations are less than 90% on room air, or low blood pressure or high heart rate, then they will consider putting this patient to interventional arm. Otherwise, they will just give the patient analgesia and assess the patient after 4 hours. It will be final assessment. Obviously, patient will be monitored in the ED department or medical assessment unit. And at that time, they will repeat a chest X-ray. If patient remains stable, it's mainly very much patient focused. If patient remains stable, patient can walk comfortably around ED department, you will discharge the patient. If patient is not able to walk, patient symptoms are getting worse, or vitals are getting worse, then you will put the chest drain, otherwise not. Very brave approach. The interventional arm, you will insert a small bore chest drain, which will be less than 12 French. Repeat assessment after 1 hour after insertion of the chest drain and repeat a chest X-ray. If symptoms reduce and pneumothorax is small, by the way, they measure the pneumothorax size by a totally different method, which is the Collins method. It is an equation in which you measure the distance at different levels and determine how big is the pneumothorax, 60%, 70%, etc. So in this trial, most of the patients had pneumothorax more than 60%. If after inserting the chest drain, the pneumothorax has resolved, you will close the 3-way tap, do another X-ray after 4 hours. Can the patient walk comfortably and pneumothorax has not reaccumulated, you will discharge the patient. If none of them, patient is getting worse, pneumothorax is getting worse on the chest X-ray, you open the 3-way tap, continue drainage, and admit the patient for usual care. So very interesting trial, in fact. So primary outcome, chest X-ray resolution. Obviously, the patients who had chest drain inserted, their pneumothorax resolved quickly on the chest X-ray. But our primary outcome was what is happening at 8 weeks. And at 8 weeks, actually, there is no statistically significant difference. Of course, the conservative group, about 15% of the patients in the conservative group required some intervention later on. But obviously, the intervention group, 100% of them had some sort of intervention. So the primary outcome was reached, actually, is the conservative approach is non-inferior to interventional approach. And the secondary outcomes were, there were fewer adverse events, fewer recurrent pneumothoraces. When it comes to symptoms, I mean, this is very surprising that whether you observe the patient or whether you put the chest drain, there was no difference in symptomatology of chest pain and shortness of breath. No, you will argue that the patients who you have sent home without doing anything, they will do worse from adverse events point of view, but rather it is the other way around. Really, the interventional group whom you admitted by inserting a chest drain, they had more adverse events. Obviously, if you are inserting a chest drain, then you accept all the risks associated with chest drain insertion and for hospitalization as well. So more adverse events in the interventional arm as compared to conservative arm. And this is very surprising even to the trial scientists. So that if you don't intervene into the chest of the patient, then the recurrence of pneumothoraces at 12 months was less. Obviously, if you do intervention, you make a hole, then these patients will tend to have more recurrences, which is quite surprising. I think I put it other way around. So in summary, if you intervene in each and every patient really for primary spontaneous pneumothorax, you double the risk of recurrence. So the recurrence rate at 12 months in the intervention group was 16.8%, and in the conservative group was 8.8%. You quadruple the number needing surgery later on, which we usually refer at 3 to 5 days after insertion chest drain if there is no resolution. Increased length of stay without saying that 6 days for the intervention group, 1.6 days for the conservative group. Increased days off work. If you are having chest pain and hospitalized, you will stay off work more. And obviously, if you are keeping the patient in the hospital, you're doing more chest X-rays and CTs to determine the resolution, etc. And adverse events were more in the intervention group. So very clear results. And in fact, if you look at the BTS guidelines very clearly, at the bottom of the BTS guidelines in 2010, they do mention that in some patients with large pneumothorax but minimal symptoms, conservative management may be appropriate. But this is not followed actually. But no, we have got a randomized controlled trial results in front of us, and this should be followed. Option 2, so we have talked about conservative management, doing nothing. Option 2 is ambulatory management. So you may have seen this Heimlich valve. This is a one-way valve which is attached to the chest drain, and there's no underwater seal. You insert the chest drain, attach it, and send the patient home most of the time, and this will just let the air out. There is another device developed by Rocket company. It came into the market in 2014. It is a 8 French catheter mounted on 18 gauge needle. Okay, it's a self-contained device with a one-way valve again, and you don't need a chest drain insertion for this patient. You just make a small nick, insert it into the second intercostal space in mid-clavicular line, and device will take care of everything. And this is an adopted version of Heimlich valve. It is pneumostat by Atrium company. So basically, it is Heimlich valve, but they have introduced a 30 ml collection chamber in case there is any pleural fluid comes out, which you can collect. But it is a kind of Heimlich valve. So these are the 3 options available for ambulatory management of patients if you just want to put a chest drain or pleural vent and send them home. Nick Maskell is a guru of pleural diseases from Bristol, UK, and he has done a systematic review of ambulatory treatment for management of pneumothorax and published in 2013. There were 18 studies from 9 countries, and he found more than 1,200 patients who had used Heimlich valve, this type of valve mainly. There were moderate to poor quality of the reports, all case series, 2 randomized controlled trials, but underpowered. And they suggested that outpatient management can be successful in nearly 80% of the cases, but is not a robust evidence. The evidence is poor, moderate. I would like to talk about this device, Rocket pleural vent, because I was involved in this one. This was produced by Rocket company in consultation with our unit in Leicester, UK. When I was a fellow there in 2014, I had the opportunity to work with the team who were trialing this device first time ever in the world. So this is one of our first patients. We inserted this device, pleural vent. You can see it. It's a 19-year-old chap who came with primary spontaneous pneumothorax. And this is one of the first patients in the world. We put this device. And this did work. So I was involved in trialing this new pleural device, and to check the efficacy and safety, obviously you do want to determine whether it works or not. So we presented our findings at European Respiratory Society meeting in 2015. We inserted in 10 patients, all of them actually, irrespective of whether it's a primary spontaneous pneumothorax or secondary spontaneous pneumothorax, irrespective of the age, all patients. I used to go to even our admission unit and find the patient with pneumothorax and insert this one, and we found the outcomes that it is safe and effective. Obviously, we did not include the iatrogenic pneumothorax patients or traumatic pneumothoraces. In 9 out of 10 patients, it worked. In 1 patient, there was a blockage of the pleural vent next day, and we have to convert it to a chest drain. But largely, it did work, and we did present our results at 2015 ERS that it is a safe and effective device. Some of you may be interested in Formula One racing, and that is what havoc happened in Abu Dhabi last year. You may know that obviously I'm a fan of Lewis Hamilton. So on the last lap of the race, due to, I think it's a human error, it's called, Michael Messi, who was the race director, he did not follow the rules properly, and Max Verstappen surprisingly became the champion of the Formula driving. And there have been a lot of hoo-ha in the media. The reason I'm describing this is that in the Formula One racing, there is a continuous monitoring of the car and tires and everything. How they monitor the pressure of the tire is there's a small chip in the tire, and the team monitors it, obviously, if they have to do pit stop, etc. And at that time, when we were trialing this device, and there was a suggestion, why not we put similar chip into this device as well, even if patient is going home, and we can monitor the pleural pressure remotely. And when the pleural pressure is low or pneumothorax is resolved, we call the patient in and remove the device. But this did not materialize. But this is one of the concept I really liked it. I mean, maybe the new generation who are good in technology may come up with some idea like this. So Oxford took this idea from us, and they planned a randomized controlled trial on this device. So we did our case series in 2014. In 2015, they were quick to undertake a randomized controlled trial, which is the right approach, and that is how we should be doing it to assess this device properly. So this is a RAM trial. Basically, the randomization is, so you get a patient with primary spontaneous pneumothorax, and you determine they require an intervention and randomize into ambulatory treatment with pleural vent. You will put a pleural vent and send them home, or standard care according to BTS guidelines, i.e. you will perform a pleural aspiration if size is more than 2 centimeters or patient is symptomatic. And if that doesn't work, you put a chest drain and admit the patient. Primary outcome was hospital stay over 30 days, and patients were followed up for 12 months in total. Primary outcome was hospital stay, and there was secondary outcomes, pain and breathlessness, need for further procedures, and complication rates. These are the characteristics of the patient. So you can see in the ambulatory care group and in the standard care group, patients are quite symptomatic really. 89% patient had breathlessness, and up to 92% had pain. So they are quite a symptomatic group as compared to the PSP trial, which were not very symptomatic. And majority of the patients were current or ex-smokers. And interestingly, you can see that 30% of the patients, these are young blocks with primary spontaneous pneumothorax, with the mean age of 31, and they were using marijuana. And they were currently 30% were current and 17% were the ex-smokers in the ambulatory care group. So this is an interesting finding, and you know the cannabis has been legalized in many countries, including Canada. Apparently, you can carry about 30 grams of cannabis in your pocket, and police will not catch you. Primary outcome, total hospital stay within 30 days. You can see it is a 0 day for ambulatory care and 4 days for standard care. Similarly, in hours, 4.4 versus 70 hours. Treatment duration was less in the ambulatory care, and time of work did not differ. In the conservative group, the people who did not have any kind of chest drain or ambulatory device, the conservative group did have less time of work, but in this trial, time of work was the same in both groups. And this is another way of presenting it. You can see that in the form of histograms. So patient discharged on the same day. In ambulatory care group, it was 65% of the patients were discharged on the same day. In the standard group, only 33% patients were discharged on the same day. So the primary outcome was achieved. So in conclusion, there is a clear benefit to ambulatory strategy in reducing hospital stay if you want to. And 21% of the patients who were put to ambulatory care required further procedure. But obviously, they were fewer than the standard care. The BTS guidelines are being revised at the moment, and they will be published anytime soon in next few months. So watch this space. But if I have to devise the new BTS guidelines today, So that is how the new guidelines for primary spontaneous pneumothorax will look like. So we have removed the size doesn't matter. You find the patient with primary spontaneous pneumothorax, ask the patient about symptoms. If there are significant symptoms, you insert the ambulatory device, which is pleural vent, and regular review as outpatient. Once pneumothorax is resolved, you remove the device. If patient does not have any significant symptoms, really, you discharge the patient without doing anything according to PSP trial and review in 2 weeks. Surgical treatments, obviously, we can't ignore our surgeons for primary spontaneous pneumothorax. So there has been a very good epidemiological study from Oxford, which found that the recurrence rate at 1 year and 5 years is quite high, even for primary spontaneous pneumothorax. And if you do CT scans on all these young patients with primary spontaneous pneumothorax, you will find lots of blebs and bullae. So some people argue that do we need to reclassify primary and secondary pneumothorax, because many patients with primary spontaneous pneumothorax will have abnormal lungs anyway. So this group from Denmark, I think it's Denmark, what they did is they did CT scan on all the patients with primary spontaneous pneumothorax, young and healthy patients. For the first episode of primary spontaneous pneumothorax, and primary endpoint was ipsilateral recurrent spontaneous pneumothorax over 1 year, and they used this dystrophic severity scoring system, which depends on the number of blebs or bullae in the lung based on the CT scan. They randomized the patients into direct VATS treatment or chest tube. Obviously, the recurrence rate with VAT procedure was less than the chest tube. And if you have got a bullae more than 2 centimeters, and there are high chances of recurrence, obviously, these patients had more benefit from VAT surgery. So there is some role of surgery, but it is an invasive procedure, as you know. So indication for VAT surgery, I will not send the patient directly to surgeons. So I will send the patient to surgeons if there is a lack of expansion of the lung at 3 to 5 days, spontaneous hemothorax, second ipsilateral pneumothorax, bilateral pneumothorax, or there are professions at risk. Yes, and those are the, for example, some pilot comes with primary spontaneous pneumothorax, or divers who are at risk of getting recurrence due to their profession. I will send them to surgeons straight away. Yes, that is the exception. Otherwise, these are the indications for VAT surgery. A few slides about secondary spontaneous pneumothorax. Obviously, it is a different disease, and these patients have got abnormal lungs. Usually, they have been smoking heavily, and there's a high rate of recurrence in these patients. The management of secondary spontaneous pneumothorax can be challenging, and they require prolonged inpatient stay usually. So there is a small trial on the ambulatory management of secondary spontaneous pneumothorax from Bristol again. So it was a open label trial using Heimlich valve, basically. Primary outcome again, total number of hospital bed days. So you identify a patient with secondary spontaneous pneumothorax, provide a standard care with chest drain and underwater seal, or you put a rocket pleural vent, which we discussed before, or we use the atrium pneumostat. And this trial ran over 3 years, only 41 patients, and it did not work. For secondary spontaneous pneumothorax, there was no difference in length of stay in the first 30 days following treatment intervention. So in fact, the pleural vent, because it is only an 8 French catheter, it did not cope with the level of leak. So there was a negative outcome. Though the patients treated with the atrium pneumostat device had no early treatment failure and length of stay was less. So atrium pneumostat device is good, pleural vent is bad when it comes to SSP. And that is what it is, basically the summary of this small trial. We talk about personalized treatments for different diseases. I think there is a personalized treatments for pneumothorax. We don't want to overtreat the patient, but at the same time, we don't want to undertreat as well. So there are radiological predictors. I briefly mentioned about dystrophic score on CT scan in primary spontaneous pneumothorax. You can use that. Or there is a new digital suction device, and this is called Topaz digital suction device. You insert a chest drain, put this one at the end of it. It will perform suction for you and also measure the level of the leak. So these are the parameters you can use, which patient will have success and which patient will fail. So we use this Topaz digital suction device quite regularly, and patient can walk with it. So coming back to our patient, which I described earlier. So I hope that I have managed to change your mind now. So my answer for this patient, 19-year-old bloke with primary spontaneous large pneumothorax, will be insert a pleural vent and regular follow-up. And I think that is what will come in the new guidelines whenever they are published. I will definitely not insert a chest drain in this patient. I will definitely not send this patient to surgeons unless he is a pilot or diver. He will not be a pilot at the age of 19. And manual aspiration, yes, you can, but manual aspiration has got 50% failure rate. Or conservative approach only if patient is asymptomatic. So the respiratory community is changing their mind really, and there's increased evidence about ambulatory management and conservative management, and people are saying stop putting chest drains as first-line therapy into the chests of the patient. They are painful, cause complication, unnecessary hospital treatments. And in fact, I remember one young patient whom I told that you need to stay in the hospital, and he said, "Doc, do you have a good quality internet in your hospital or not?" I said, "I can't guarantee that." He said, "If I can't watch YouTube or Netflix, I'm not staying in the hospital." So really, they don't need to stay in the hospital. They have got an ambulatory device inserted and go home. And I feel guilty keeping some patients, young patients who are preparing for, who have got their O-level or A-level exams coming up. And they beg you, please send me home, doctor, but you say, no, you have to have chest drain and stay in the hospital. But with this evidence, these patients can be treated through ambulatory pathway and sent home. So in summary, so pneumothorax management in 2022, what I will do if we follow the evidence. If there are no symptoms in the conservative management is okay. If there's a significant shortness of breath, ambulatory device management. Obviously, if there are social issues, failed conservative ambulatory management, patient lives very far away from the hospital, and put a chest tube and attach a topaz device. High risk groups like pilots or divers or second episode, consider straight to VATS. When it comes to scandi spontaneous pneumonia, this is a different group. Ambulatory management is not very well established for this group. Be more cautious, likely to be more symptomatic. There's a role for chest drain insertion. Consider tall pleurosis in this patient to reduce the recurrence, and consider atrium pneumostat to ambulate this patient and reduce length of stay. In fact, there are patients you will come across who have got scandi spontaneous pneumothorax, and they have got persistent leak, and they are not fit for surgery for some reason. So in those patients, you can put atrium device. I have successfully managed many patients who have got persistent leak and send them home, and with regular follow-up. We have to do patient-centered treatment. We have to ask the patient perspective and involve them more and more in their treatment, as I have given you a few examples. It is not all about the size of the pneumothorax and chest X-ray. It is the patient wishes as well. If patient is asymptomatic, do you really need to do anything? I remember another patient who was needle phobic. About 40-year-old lady came with large pneumothorax, and she will not let anyone go near her with a needle. And she self-discharged from the hospital. Wow, we thought she may die with this pneumothorax, but she came back after 3 weeks, almost complete resolution of the pneumothorax. I think we were stupid at that time. And early risk stratification and triage of patients using personalized model, yes, through TOPAZ, through dystrophic scores as well. So really, I sum up here that the evidence is there, but generally in respiratory medicine, we have been slow in implementing it. There are many stakeholders when it comes to the management of pneumothorax, which is not a bad thing, including emergency physicians, acute medics, respiratory physician, thoracic surgeon, interventional radiologist. But really, we need to embrace this evidence and try, whenever you are going to insert a chest drain for a patient with primary spontaneous pneumothorax, please do ask yourself, can I treat this patient conservatively if patient is asymptomatic, or I can send this patient home to sit in the comfort of their own home and reduce the length of stay in the hospital by doing ambulatory care. Thank you very much for your attention.
Thank you so much, Dr. Mohammed. This was very interesting, and I hope by the end of this day, some people can change their mind if these devices are available. But thank you very much. I do have a question, but we will keep it at the end. And now we will move on to the next session for tonight with Dr. Jihad Abdullah, who is an ID consultant in SKMC Al Rahba, and he's an American board certified internal medicine and infectious diseases. He'll be talking about adult pneumococcal vaccination and what's new. So please go ahead, Dr. Jihad. We'll listen to you right now.
Okay. Thank you very much for the introduction. Okay, let me remove this bar. 1 second. So we're going to talk today about pneumococcus vaccine. And first, we're going to talk about some serious complications of the strep pneumoniae, also how it's spread. There's a new guidelines regarding the streptococcus pneumoniae vaccine. We'll go through some barriers when it comes to strep pneumonia vaccination, especially during this COVID pandemic. And we'll talk about some strategies to improve the uptake of the vaccine during this special period. So first, we're going to go through some 3 cases of streptococcus pneumonia infection with some complications, and let's figure out what do they have in common. So the first case is a 67 years old male patient with history of sickle cell disease and functional asplenia. And whenever I put any past medical history involved, pay attention to that, because there is a reason for that. Beside the asplenia, there is hypertension. The patient was admitted with shortness of breath, generalized weakness, nausea, and diarrhea. Started 1 day before. He's a smoker. He has been smoking 1 pack of cigarettes a day for the last 40 years, no alcohol. This patient, who is 67, again, I put this in bold font, refused pneumococcal vaccine as well as the influenza vaccine because he was afraid of vaccinations and the possible side effects. Upon admission, the patient was found to be hypotensive, and he had a temperature of 38.4 Celsius. He had leukocytosis with lift shift. He had anemia and thrombocytopenia. He had acute renal failure because there is no history of renal impairment before. He had elevated lactic acid 4.3, elevated liver enzymes, and fibrinogen was high, as well as LDH and D dimers. His peripheral blood smear showed elevated white blood cells with neutrophils and schistocytes, and there is a manifestation of microangiopathic hemolytic anemia. The chest CT scan of the chest CT scan, abdomen CT scan, and pelvis without contrast was negative because there was no clear diagnosis and why this patient is septic. So there was no abscess, no ischemia, anything pointing at colitis or ischemia. So the patient was diagnosed with severe sepsis, but no obvious source of infection, admitted to the ICU, and he was resuscitated with fluid and given broad spectrum antibiotics. But within the next few hours, as you can see, he developed multiple skin patches. As you can see, it was retiform purple patches with central dusky necrosis. And after a few hours, it became really ischemic, as you can see in the bottom photo. So the patient's blood culture grew streptococcus pneumonia. So this is a case of pneumococcal bacteremia, including septic shock, multi-organ failure, and disseminated intravascular coagulation, DIC. Let's go to the next case, case number 2. So now we have an 80 years old, and again, I put this in bold, male patient admitted with dyspnea, cough, with brownish sputum, as well as fever and chills for 2 days. Past medical history was significant for diabetes mellitus and hypertension. No previous vaccination since childhood. He's 80 years old, and since childhood, no any vaccination. Physical examination revealed high temperature, 39.2, crackles in the right lower lobe. He was obviously out of breath. Saturation was 92% in room air. Labs showed a white blood cells of 12,000 with 85% neutrophils. His CRP and procalcitonin were elevated. The patient was started on IV antibiotics. His blood and sputum culture both grew Streptococcus pneumoniae. He was intubated after 48 hours of admission. Chest X-ray on day 1, as you can see on the left side, showing the right lower consolidation. But few days on day 3, there is bilateral diffuse infiltration. After antibiotics resuscitation, his situation improved, as you can see in the 3rd chest X-ray on day 7. So we have a case of invasive Streptococcus pneumoniae infection, which was a mix of severe bacterial pneumonia and bacteremia. And the 3rd case is a young male, 8-year-old boy with past medical history of cochlear implant. He presented to the ED with headache for 3 days, as well as fever and vomiting for 1 day. No vaccination given since his cochlear implant. His neurological symptoms progressed over the next several hours until he became disoriented. He had fever 39.4 Celsius with the disorientation. LP was done and it was milky white. White blood cells was 2000 with dominant neutrophils 91%. And the gram stain showed gram-positive diplococci. The blood and the cerebrospinal fluid cultures both grew Streptococcus pneumoniae, sensitive to all antibiotic tested, and Streptococcus culture from the throat was negative, and patient was diagnosed with pneumococcal meningitis, and given ceftriaxone, ampicillin, and vancomycin, his condition improved. So here we have a case of invasive Streptococcus pneumoniae infection, including bacteremia and meningitis. So what do they have, those 3 cases in common? All of them were unvaccinated. All of them ended up having invasive pneumococcal disease. So Streptococcus pneumoniae is still the leading cause of bacterial pneumonia all over the world. Let's start with this question. So Streptococcus pneumoniae cases have increased since we had this pandemic, the COVID-19 pandemic, compared to the pre-COVID period. True or false? And the answer is false. So as you can see, this study from England, and as you can see in the left side purple side here, this is the cases of the invasive Streptococcus pneumoniae infection. And once the pandemic started and lockdown was implemented, as you can see, the cases went down. And maybe this is part to the use of mask and social distancing. But on the other hand, the case fatality rate, when you have both Streptococcus pneumoniae infection and COVID, was high, although it was rare cases, but with high mortality rate. Same thing we found in a Japanese study. So the rate of co-infection, both coronavirus and Streptococcus pneumoniae, was rare, but when it happens, the case fatality rate was higher than normal cases. Also, this they noticed that in Italy during COVID-19 pandemic, the first wave that hit Italy in a hard way, mainly in the northern Italy, wherever there is cases of invasive pneumococcus disease, the mortality rate for COVID-19 was higher. The same places, although they did not go and check every single case and check whether it's the same case that they had, it had the pneumococcus infection, but there's somehow a link between the rate of IPD, invasive pneumococcal disease, and mortality rate when it comes to COVID-19 infection. So Streptococcus pneumoniae, as we know, it's a gram-positive bacteria. There is multiple serotypes, around 92 serotypes. And the polysaccharide capsule is the virulent factor in this bacteria. And there is no any specific antibody protective for all of them. It should be for certain type by type. So you can't have antibody that covers all the serotypes in one shot. Pneumococcal disease can affect the brain, the meningitis can affect the lung, joints, it can affect the sinus, multiple places. But usually the most common risk factor is colonization with this bacteria, the Streptococcus pneumoniae. So if you are colonized, you can develop either the sinusitis or pneumonia infection or even otitis media, or it can spread through the blood and gets to distant places, whether it's the joints, whether it's the blood vessels causing septicemia, or even to the pericardium and pleural space causing empyema. So the pneumonia and also the sinusitis and otitis media are way more common than the bacteremia, meningitis, and peritonitis, as well as osteomyelitis or arthritis. You are contagious either if you have infection with Streptococcus pneumoniae or even if you are colonized without any symptoms. Either way, you can spread the disease. So having like immunization for vulnerable population will reduce colonization and improve or slow the spread of disease. And in personal level, if you are immunized, this will give you a mild disease versus, or no disease, of course, versus severe disease, as we saw in the first cases. The same thing we mentioned, so you are colonized or infected, you can spread the bacteria either locally or by blood to distant places in your body. So whether you have meningitis or bacteremia, this is called invasive pneumococcal disease. Pneumonia with bacteremia is called also invasive pneumococcal disease. Otitis media, sinusitis, or pneumonia without bacteremia is just non-invasive disease. In 2017, there is more than 100,000 hospitalization in the US due to pneumococcal pneumonia. Out of these, 3,000 deaths due to invasive pneumococcal disease. Most of those cases, as you can see, 43% in all population, people above the age of 65 years old, or if younger, between the age of 19 to 64. And here we're referring only to adults. I'm not talking about pediatric population. This is only adults, 19 to 64 years of old, only when they have risk factors. I will go through this. So if you join both of them, people are above the age of 65 and younger population with risk factors, this is the majority, more than 90% of people who will develop invasive pneumococcal disease. And those the ones who need the vaccine desperately. So we used to have two vaccines. We used to have PCV13. So it's pneumococcal conjugate vaccine 13. And from its name, it covers 13 serotype. And we used to have polysaccharide vaccine, pneumococcal polysaccharide vaccine 23 that covers 23 serotypes. This one is out of the equation. Now it's not recommended by European guidelines and CDC in the US, but the PPSV, the polysaccharide, still there and recommended. And we have newcomers, two newcomers. We have the PCV15 and the PCV20. And from their name, so let's start with PCV13. As I told you, it covers 13 serotypes. Now, PCV15 will cover 2 more of those serotypes. Of course, 20 will cover another 5, covers total of 20 serotypes. And our old friend, the PPSV, the polysaccharide vaccine, covers 23, but there is a hole in the coverage. It's the As you can see, we call this 6A serotype. It's not covered, and it's covered by the first three. When it comes to comorbidities and baseline disease, lung disease such as COPD or heart disease such as CHF will have the most risk factors of developing invasive disease and community-acquired pneumonia. As you can see, the older you are, the more likely you get the disease, the invasive pneumococcal disease. When I say invasive, I mean bacteremia, meningitis, or pneumonia with bacteremia. So I put a circle here around the age 50 to 64. The guidelines does not recommend giving pneumonia vaccine to people under the age of 65 when they don't have any risk factors, when they don't have any comorbid condition. But as you can see, there's around 15% of those developing invasive disease. And the reason for that, as you can see here, the same thing. We think, well, not me, the people who wrote the guidelines, that giving such a group of patients the vaccine is not cost effective. And in fact, they think that if you give it early, by the time you get up to 65 years old, you have a weakened immune, and there is waning antibodies from the first vaccine you got. So it's better to give it at the age of 65 and above. So this is what I mentioned. So the new guidelines tell you the following: either you give PCV20 alone, or if you don't give it, give PCV15 followed by polysaccharide 23. This is for the people above the age of 65, or people, younger people 19 to 64, but with risk factors. The risk factors are huge, so I summarize it in the next slide. So when it comes to habit, if you have alcohol problem or alcohol abuse or cigarette smoking, you are considered with high risk. And if you are between the age of, above the age of 19, you should get the vaccine. And cigarette smoking alone will put many adults in the category of being eligible to get a pneumonia vaccine. Chronic conditions, whether it's diabetes mellitus, heart disease, such as congestive heart failure or cardiomyopathy, lung disease such as asthma, COPD or emphysema, liver disease or renal failure. This is the chronic condition. Immunosuppressive condition, as you can see, anything with whether it is congenital or acquired, or people without spleen, whether it's acquired or congenital, HIV, malignancies, people on steroids, people on status post solid organs transplant, sickle cell disease, or any other hemoglobinopathies, any one of these, or even blood malignancies, leukemia or lymphoma, Hodgkin lymphoma, all of these will put you in the category of high risk population, and you should receive the vaccination. Finally, if you have cerebrospinal fluid leak or cochlear implant, as I mentioned in the third case, you should get the vaccine. Again, to summarize that, if you are a young adult between the age of 19 to 64, and you never received the vaccine, or we don't know about your status of vaccination status, you either get PCV 21 dose, and that's enough, or PCV 15 followed by PPSV, the polysaccharide vaccine 23 after 1 year. If you have certain risk factors, such as cochlear implant or CSF leak, or anything that will bring your immune system down, it's better to give it earlier than a year when you give PCV 15. So you give PCV 15 followed by PPSV 23, 8 weeks or later. You don't have to wait 1 year to give it. Again, the same thing for people above the age of 65. Either you give 1 dose of PCV 20 or PCV 15. If you give PCV 15, you should follow it with PPSV 23 1 year later. People with immunocompromised condition, all people with that condition, immunocompromised or CSF leak or cochlear implant, you can give the PPSV 23 earlier, 8 weeks or more after the PCV 15. Again, this is a easy summary. Either you give PCV 20 alone, this is enough, no other vaccination required, or you give PCV 15 followed by PPSV, the polysaccharide vaccine, 12 months earlier. And as I mentioned before, if you have immunocompromised condition, or you have CSF leak or cochlear implant, then you can give the PPSV 23 8 weeks later. You don't have to wait a whole year. The same thing we mentioned. So in the era of COVID-19, our hospitals are almost full. The staff are already stretched to the max. And it's, if you add another burden on top of the COVID, whether it's influenza infection or pneumococcal infection, this will put extra burden and add harm to the injury, and we don't need that. So to prevent that, the simple, easiest way is vaccination. Vaccinate against influenza, vaccinate against a pneumococcal disease. Then if you have COVID infection, at least we have to deal with one infection rather than co-infection. And I showed you earlier that the case fatality rate when you have combination COVID-19 and pneumococcal disease is higher than one alone. This is a nice study published in and done in France, and they looked at healthcare professionals and whether they check the status of their patient and recommend pneumococcal vaccine, or even both pneumococcal vaccine and influenza. And as you can see, unfortunately, whether it's a general practitioner or specialist, or even a pharmacist, the rate of checking the status of the vaccine and recommending that and explaining to the patient the importance of the vaccine is really shocking. It's always less than 50% for those certain population, certain kind of patients who needed this the most. And when you take it the other way around, we went in this study and asked, not me, of course, the French people, asked the patients whether they were informed about the need for pneumonia vaccine. Someone talked about it, someone recommended. And as you can see, shocking results, only 49% were informed. And see the patient category. Transplant patients, 69% were informed and suggested for vaccine. Inflammatory skin disease, autoimmune disease, cardiovascular, all those high-risk population. Not everyone was informed about the importance of the vaccine and the need to be vaccinated, which is shocking. So as healthcare workers, we have a task we have to always adhere to. We have to assess the vaccination status of our patients, whether it's pneumonia vaccine, whether it's influenza or other important vaccines, and recommend the vaccine to our patients as needed. And if we can administer those vaccines, do it. If you cannot, you do it in your clinic or your hospital or your place. Refer the patient to a place where he can get the vaccine. And of course, always document vaccination status and be always ready to check the status of the patient's vaccine anytime. Thank you very much.
Thank you so much, Dr. Jihad, for this rather interesting presentation. The updates were very interesting, and I'm sure a lot of people were wondering what was going on regarding that. There was a question regarding that, and I think he got his answer. But let's say if you can on your mic and your camera as well, Dr. Mohammed Tafil, so we can start our Q&A session. And if there are anyone from the audience who would like to type in their questions in their Q&A chat box also, it will be better. So I'll just, if you can elaborate more, Dr. Jihad, regarding the vaccination after getting the infection itself. So you don't know the status of a patient's vaccines, and he got the streptococcal pneumonia in the blood, so it's a septicemia. And then he got treated. So when do you plan to vaccinate him, or what is the plan will be?
Usually, if he's symptoms free, most of the time, by the time he leaves the hospital about to be discharged, or the first clinic visit, I do not delay it beyond that.
I see. I see. So even if it was it doesn't matter if it was a septicemia or it was just a pneumonia, or you just vaccinated.
Recovered, symptoms free, he's eligible to get the vaccine now.
Okay, that's great. Yes. There was another question for Dr. Mohammed Tufail as well regarding travel. You know, travel guidelines after pneumothorax are very clear, but you always get this patient who really wants to travel tomorrow after getting treated for a pneumothorax, or let's say they want to travel and they still have the pneumothorax and they don't want to stay overnight. The same topic. So what's your experience regarding using the Heimlich valve or the pleural vent, is it so, and travel? Will you put it and let him travel, or if you can elaborate on that as well?
Absolutely. Thank you. It's a very interesting question. Obviously, when the trial I mentioned in primary spontaneous pneumothorax trial from Australia and New Zealand, if you are treating some patient conservatively and not doing anything for pneumothorax, then one of the caveat is patients can't travel. Once pneumothorax has resolved, usually we advise that if patient is asymptomatic, oxygen saturations are okay, after primary spontaneous pneumothorax, really 1 week is enough. After 1 week, you can travel. Answer to your second question, whether if someone has got persistent pneumothorax, we can put an Heimlich valve and let them on the plane. Yes, I have done it for a couple of my patients successfully. I always remember one patient who had mesothelioma, and he had persistent pneumothorax due to that, and he did want to go to see his family in America from UK. We put the Heimlich valve at the end of his indwelling fluid catheter, and he traveled safely.
That's very interesting as well. Yes. Just checking in the Q&A. So let's take this question. Why is the vaccine not given to the general population, considering the fact that 48% of invasive disease takes place in age groups between 19 to 65?
No, it doesn't take 49 with risk factors.
Correct.
So without risk factors, the risk is very low. That's why. I noticed that 50 years old and above, there's 15% risk of acquiring invasive pneumococcal disease. But younger, without risk factors, the one we mentioned, whether it's a habit, smoking or alcohol, or medical condition, immunosuppressive conditions, there's no risk. Or like minimal risk. We can't say always there is no risk.
I see. There is another question. How about healthcare worker can have PCV1 vaccine? Do you recommend to give PCV for healthcare workers? I don't know. I'm not sure, but
healthcare workers without, there's no specific mentioning of pneumonia vaccine if they don't have risk factors, to be honest. As I showed you the list, it's not being a healthcare worker, it's not in the category. So unless you are, unless you have risk factors, diabetic or a smoker or any other problems, no need. I noticed there's a question, what's the Dubai guidelines regarding the pneumococcal vaccine? And in fact, because they don't have yet the PCV20 or PCV15, so they're still holding the old guidelines. Let me share my screen. I have a slide about that. Let me see if I have it here. I don't know if you can see my screen here.
Yes, it's clear, doctor.
So here, so we, as you can see, you start with PCV 13, still available in Dubai and UAE. And then after 1 year, you can go for 23, the polysaccharide 23, okay? So the old recommendation is still holding here in Dubai until we get the new ones, the PCV 15 and 20.
Right. Sure. There is another question, I think, for Dr. Mohammed Tufail, regarding primary pneumothorax. Is it always the case that we start needle decompression, then chest tube, or there are cases where we jump directly to chest tube immediately?
Actually, none of them. So the current guidelines, which are current, I mean, American guidelines are from 2001 and BTS guidelines are from 2010. And over the last 3-4 years, and we have come across quite a few randomized controlled trials with quite a good evidence about ambulatory management of these patients. So if you keep the guidelines on one side and we just talk about the guide, because by the way, the BTS guidelines are going to be renewed soon in next few months. Just you will get the new guidelines, and I'm telling you about those new guidelines now. So if there is a patient with primary spontaneous pneumothorax, they are symptomatic, irrespective of howsoever big the pneumothorax is, and if patient is young, healthy, fit, and lives near to the hospital, can come to the hospital in case of any problems. You put an ambulatory device in these patients, pleural vent, and send them home. We don't want these young blokes, young patients staying in the hospital. We just want them to be at home, enjoy their Netflix and YouTube, and come back to our clinic in 2 weeks' time.
Actually, we want them to change, to come out from the Netflix.
Absolutely. I mean, this is a young population, and from your experience,
yes, very hard to
they don't like to
them.
stay in the hospital, and we have got enough evidence for ambulatory management.
Correct. Yes. There is actually, I think this is a continuation from this theme. Regarding the pneumothorax, if you send them home and there is a risk of rupture, and then they would come back with complications. I think this is the question, if I'm not mistaken. There are a lot of patients present with pneumothorax firstly to ambulatory care rather than the AD. And by that time, the patient is finally referred to the AD, it would have been already ruptured. Any role of physicians in the ambulatory care being able to insert the device, whether it was pleural vent or atrium pneumostat? What's your advice? Yeah, it's completely different than what I said, but yes, interesting. Yeah.
Absolutely. I mean, all these trials have taken into account the patient perspective, really. I mean, if patient, it depends how symptomatic the patient is.
Okay.
If patient is asymptomatic, you could argue you do nothing. You send them home and bring them back for a repeat chest X-ray, or just give them an advice that if your symptoms get worse, come back. But yes, if patients comes in ED, our instinct is that just put a tube into the chest of the patient and admit them in the hospital for 4 to 8 days. And obviously chest pain is painful as well. And you make a 1-inch hole in the chest of the patient, and they get more pain due to the chest pain than due to pneumothorax. And yes, I mean, in ED, we have to work very closely as a respiratory physicians. I think it is very important that we work very closely with the ED to facilitate ambulatory management of the patient. At the moment, we tend to put more and more chest drains. I think ambulatory devices should be available, and pleural vent insertion, a very simple thing. It takes 5 minutes to do it. Really, you give local anesthesia in second intercostal space, make a small nick, and insert this 8 French. It's I think as simple as putting a venflon or cannula into the patient. So it's not difficult.
I see. Thank you very much. I think last but not least, I agree about the risk factors, but considering the fact that it is a very common infection, this is, I think, for Dr. Jihad. So someone is just commenting about after multiple infections, if we can avoid the infection by mass vaccination, then we can avoid formation of resistant groups, and we will be able to tackle it without broad spectrum antibiotics. So this is an advice, I think, from one of the audience for Dr. Jihad. But yeah, I mean, after the COVID pandemic and the vaccination campaigns that happened here among major countries, I can see that the UAE has done a very great job in vaccinations, whether for COVID and other. But I think, yes, this is excellent. If you have any...
problem is cost effectiveness. This is the problem, Yani it's an ideal scenario to go and vaccinate everyone above the age of 19 and khalas, done. But it's not cost effective. That's why I see that there's a question, to be honest. Obesity, is it a risk factor for getting Streptococcus pneumoniae infection? And the answer, I'll share my screen. I'll show you that again. I have this one slide. I don't know if you can see it now.
Yes, it's clear.
So, sorry. Okay, sorry. It's in slide here. So it is not, it is obesity, as you can see here to the left side, has minimum effect on the disease. On the other hand, COVID-19 infection, obesity is a very important risk factor in developing severe disease. So Streptococcus pneumonia infection, no, not a big deal here. Okay.
Excellent. Okay, and there is a question, Dr. Jihad, since we're on the same page, regarding TB treatment. Like after TB, the patient completed TB treatment and the patient took Prevnar 13. Is it advisable to take another pneumococcal vaccine for TB?
So again, if you go by guidelines, TB is not one of them, but sometimes with extensive bilateral TB, pulmonary TB, when you have cavitary lesions, the structure of the lung parenchyma is distorted and not back to normal again. And those people, it's good to give them a pneumonia vaccine. And since you started with the PCV13, after 1 year, you have to carry on and give the PPSV, the polysaccharide 23, after 1 year. So by doing this, you complete the 2 necessary vaccines for pneumonia.
Correct, yes. I think I've read most of the questions, if not all. There is, I don't know if this is related. Did you start to study the pulmonary microbiome signature before and after vaccination?
I wish we do, but we don't. I wish we can do it for many diseases like bacterial diseases. I agree.
Yeah. But this is actually rather interesting, and I'm enjoying it. If there were, we do have time if you want to type in your questions, ladies and gentlemen, but okay, there goes another one. Vaccine 13 given once. Now we have 15, patient can take it. So if the patient, I think what they mean is that a patient has received 13 and what to do now is to receive 15.
If you receive 13 and 1 year have passed,
yes,
or has passed, you give PPSV 23. If PPSV 23 is not available, which I doubt because it's available everywhere, then PCV 20. So we prefer to give PPSV 23 if 1 year has passed. If not available, then the new one, the PCV 20.
20, yes. Okay, excellent. All right, I think by now I reached to the end, unfortunately, of this interesting session, but I would like to remind everyone by the end of this webinar, the page will direct them to the survey. So after which you can complete it, you will receive the CME certificate. So don't go ahead and close it immediately. I think I've read most of the questions, and by now I will be ending the session. Thank you so much, both Dr. Muhammad Tufail and Dr. Jihad Abdallah. It was an honor to host this event, and hopefully with upcoming events, we'll see you soon with other interesting topics, inshallah. So I wish the audience and I wish you as well a very great evening and a great weekend. Don't forget to submit the survey, and once again, thank you all for attending.
Thanks.
Thanks.
Assalamu alaikum.